Welcome to the Limitless Legal Nurse Consulting Podcast. I'm your host, Anna Gray. The best thing about being a nurse and entrepreneur over the last 25 years are the relationships I've developed and the people I've met. As a legal nurse consultant, I wanted you to hear from those amazing people in the legal and healthcare communities. I wanted you to hear who they are and to celebrate them with me. Get ready to be inspired, informed, and empowered. Let's dive into the Limitless Legal Nurse Consulting Podcast. Hey everyone, welcome to the Legal Nurse Consulting Podcast. I'm really excited to have my guest, Dr. Cohen, here today for more than one reason. One, because we're not blessed with the physicians on this podcast very often. And two, because I just love Dr. Cohen's energy and what he stands for in this medical legal world. And I really can't wait for you guys to hear all about his story and what he has to say. So thank you very much, Dr. Cohen, for being here on the podcast. I appreciate it.
My pleasure. I appreciate the opportunity. I like to talk, so that's perfect.
Perfect. We're a perfect match here. Awesome. Okay. So where in the world are you coming from?
So right now, in the last 7 years, I'm in Richmond, Virginia, and I'm currently full-time faculty at the Richmond, Virginia VA Medical Center, teaching, training, educating medical students, residents, as well as has an administrative role. So I'm board certified in both general surgery and colon and rectal surgery. I spent 23 years in the private sector before coming here, and I've always been involved in teaching, training, and educating. I think that makes me better because if I can't explain it to the residents or medical students, then I don't understand it myself. So, and I was a trainee at one time as well. And if I didn't understand it, you got to explain it to me, right? So I really enjoy this job. I enjoy working with the veterans. They're great, obviously.
Yeah.
And it's a great facility here in Richmond.
Right. So have you always been in that Virginia area, or when you were in private practice, where were you located?
Yeah, so I actually spent 20 years in Atlanta, in the big Atlanta, but an hour and a half in my car every day. We had a private practice group. I actually grew up in Southern California. I know you can tell with my hair and blue eyes. You can tell. I got it. So California, I went to college and medical school at UCLA. I trained. I did my general surgery at Boston University. I then did a colorectal fellowship at the Cleveland Clinic in Fort Lauderdale because the winters are much better there. Right. I didn't want to spend winters in the cold. And then from there, I went into the private sector. So I was a very large private practice colorectal group that we had 9 doctors, 7 offices, 50 employees, busy as can be. But then medicine changed in 2007, 8, 9, and 10. And I got tired of, being in my car an hour and a half a day. Right. Reimbursements went down in the private sector. We were fighting amongst ourselves as a group about money because that's what people fight about. Right?
Yeah.
It's the old story. So I woke up one day and I said, I'm not doing this anymore. I'm finding something else. So I actually got recruited for a short stint in West Virginia, 1 week on, 1 week off. And it was at that time that the medical legal part of what I was doing really exploded. Because my wife said to me, well, if you're off for a whole week, what are you going to do? Because you're not going to hang around the house. Perfect.
Right.
But she was used to not me being home for obvious reasons. So,
yeah.
But then from there, I was working part-time here at the VA, and then they offered me the full-time job. So the last 7 years, I've been here in Richmond.
Yeah. So you've kind of been all over the place. I always love to hear the background of, especially surgeons. Well, I'm partial to surgeons because those are who I work with all the time. And I always love to hear their background because it is typically you've kind of been all over the place. And it's always fascinating to me where they end up, where they land. And I am in Southern California, so I'm familiar with,
and I never really thought I would leave Atlanta. I mean, I took a I'm thinking I'd be there for 30 years, but things change. The physician was high, as you know,
Right.
and it was the writing was on the wall, but it was great. And it was only really serendipity that I found this particular job. I've always done the teaching, training, and educating. And that's probably, believe it or not, for my mother, who is still alive. My parents are still alive. My father's a retired general surgeon. My mom is a retired school teacher. So, even when I was in private practice, the Emory University residents would rotate with me when I was at one of their satellite hospitals. So I've always done that. And when I went to West Virginia, there's an osteopathic school right down the street from the hospital. I taught the family practice residents, chest tubes, central lines, suturing, the basic stuff. So it was great. And then here was a natural fit because most VAs are teaching facilities. So it's really been good.
So because your father was in medicine, is that one of the reasons you went down that road?
So I have an older brother and two younger brothers. All of us, believe it or not, became surgeons. And people ask me that all the time. They say, Dr. Cohen, did your parents make you go to medical school? And I said, no, absolutely not. My mom was clear from us from day one. We would all be sitting there. I must have been about 8 years old. And she would say, boys, you can do anything you want the day after you graduate med school.
That's great. That's great. And it is not uncommon that I've seen that, where their whole family, I work with a group of physicians and they're all different specialties, but they all three of the brothers, they're all surgeons. They all work at the same facility and they have a similar story. I think it's their father that is a physician. I can't remember what their mother did, but a similar story. So I always love to hear the backstory on why we decided to go into medicine.
Yeah, it's probably role model. I mean, a lot of my generation's kids did not go into medicine because there's two ways to look at it. I mean, my dad was in private practice, busy as can be from when he was never home. But looking back growing up, he made every event I was in, and I was, baseball and marching band and the swim team and water polo. He was always there. He was, from what I remember, and that may not be true, but I remember us all eating together as a family growing up. That's just what we did. And we would wait for him to get home. So, all we did was talk medicine. He would come home and tell us about a hemorrhoid that he did. So, I mean, that's kind of all I knew. But a lot of my colleagues, their parents or my friends' parents that were doctors and they did not go into medicine, they said they never saw their parents and they didn't want to have that lifestyle. So I just
interesting.
My experience was different than most, and I think that started from.
Yeah, it was a pleasant experience. It wasn't a bad experience. So it makes sense that if it was a pleasant experience, you would go down that road as well. Because why wouldn't you, right?
Right.
Yeah, I love that. Okay, so when you decided, how did the medical legal side come into play in your world? Because you're an educator, and we are natural, and we're in this medical legal environment. We are most of us are natural educators. How did the medical legal side come into play for you, or share a little bit about that story? I would love to hear that.
The first taste of it when I was a surgery resident and I was working in the emergency room and there was a gunshot wound to the head. And I was subpoenaed about 6 months later to come to court to explain to the jury that there was actually brains on the bed. Right. And I thought that was cool. Right? You see it on TV, but here I am dressed up in a suit, which I never was because I was a surgery resident. Okay. I got to take the day off, which is great. Didn't have to work that day, but I got to go to court, talk to the jury. And so that was my first taste of it. And then nothing happened until my first year in practice, where my senior partner said to me, look, I'm really busy. There's an attorney that wants you to review a case. I said, oh, what does that mean? Well, you look at the chart and you give an opinion if somebody met the standard of care. Oh, okay, sure. I'll do that. Right. So that's how it started. It was, I joined two others in practice. The senior partner was maybe, I don't know, 10, maybe 20 years ahead of me. So he had been in practice for a while, obviously.
Right.
So that was really my first thing. And then, and I enjoyed it because the way I look at it is that the entire medical legal system cannot work without physicians or medical personnel, whether it's nurses or doctors or somebody to explain what we do and why we do it. It can't. The attorneys don't know. The judge doesn't know. Jury, nobody knows, right? So it's kind of like a puzzle, right? And I think the key is even though, and I get yelled at by this all the time from defense attorneys, that you're only looking at this in hindsight, retrospect. Well, okay, right. I wasn't there 3 years ago taking care of a patient in a different state. I understand that. However, you have to put yourself in the position, if I'm standing there on post-op day 3 of a right colectomy, and the patient now is hypotensive, tachycardic, respiratory distress, screaming and abdominal pain, what is a reasonable physician supposed to do? Because I do colectomies. That is a leak until proven otherwise. And if you wait 5 days and the patient gets worse and now intubated before you even do a CAT scan to figure out that it's not a leak, that's a problem. So it's teaching juries what we do, why we do it, and explain the medicine to them, which sometimes can be a challenge because they don't get the words that we use. So it's not their fault. They don't.
Right. I have a question regarding your fellow physicians. So there are those, like you said, you were presented, hey, I've got this case, which means they were surrounded by that medical legal side of it. But I know for me, when I first got into this medical legal world and I work with surgeons, the first response that I got from them was, oh, you're working for the enemy, because they are typically scrutinized, and that's what their view of the medical legal side of it is. So what would you say to something like that? If you were asked that, I'm sure that you've come across that. Oh, you're working for the other side. What is your response on that?
Yeah, that's a great question. The residents ask me that all the time. I mean, I have not made a lot of friends doing this kind of work. You have to have a thick skin. When I have other physicians that have not done this come to me and say, I kind of want to do this. I think it's great. I hear some of the things you do. I say, okay, let me give you an example. You have to be, in order to do this kind of work, and to be credible, you can't just do defense work. You got to be credible. You got to look at it. And sometimes this has happened to me. I've gotten an email or a call from an attorney. They just tell me the case. I don't remember what side they're on. They may tell me, but I don't remember. But then a month goes by, I get to the case. I don't remember what side. And I remember talking to a plaintiff attorney or an attorney, thought it was a plaintiff attorney. I said, no, I mean, everything was right. The surgery was indicated. The operation was correct. It was a known complication. They acted right away, and the patient was fine. So you don't have a case. The attorney said, I'm on the defense. I said, oh, that's good. Okay. So it doesn't matter to me, really.
Yeah.
What I tell the residents when they ask me this question, should I get into this field? You have to be able to sit in a room across from a colleague that trained like you, that is board certified like you, look at them in the eye and tell them you fell below the standard of care and you hurt this patient. If you can't do that, don't get into this field. You have to have somewhat of a thick skin. I mean, not everybody is cut out to do it. I will tell you that.
Right.
Because I have read depositions for both sides where a newbie expert witness and lets the other side answer the way the attorney wants them to, right? Because honest enough that I know the questions they're going to ask me and how they're going to spin and twist. So it's not for everybody, for sure. You have to be an expert in your field, or at least, been doing it enough, or that type of operation, whether it's gallbladder colectomy, colonoscopy, that you can do it blindfolded. and be able to explain complications and what should happen based on education, experience, training, and using the literature, of course, if it's applicable. But definitely this is not for everybody. And even some legal nurse consultants, because I've talked to many of them, and they say, I want to just do behind the scenes. I don't want to go and testify, and that's fine. But I have, not me personally, but I know there's some colleagues that have done this that have had their life threatened. Like, I'm going to kill, other doctors that have been sued to kill you. Now, nobody's threatened me yet. I'm sure it's
right.
I certainly have had complaints that about me that I testified for the plaintiff, and unfortunately, most medical societies, and I won't mention any of them out loud, like the American College of Surgeons, is really more of a political. I hate to say it, but they're political, meaning they will protect their members, and they look down upon physicians like me that will opine on standard of care against their members, even though I am a member, right? So they definitely don't like that.
Right. Yeah, that's the experience that I've received. It's not that they won't work with me in the surgical environment, but there has definitely been a shift of conversation.
Let me tell you another example. And I've had doctors say this, so why do you work for the plaintiff? I said, I'm not working for the plaintiff. I'm giving my opinion based on standard of care, what a reasonable physician would do under similar circumstances. Thing number one. Thing number two, and I've said this to other doctors, if I get 100 plaintiff cases, what percent do you think I actually say they fell below the standard of care? It's 100%. No. I will tell you 30 to 40% of the time, and actually an hour ago was waiting for a call from an attorney to tell him he didn't have a case.
Yeah.
Surgery was indicated. The surgeon did a safe operation, the best they could. The patient had a problem 7 months later, not related to the surgery. Why is that? So I say the other way to look at it is that I save many physicians from getting sued because I tell them they don't have a case.
Right.
So
exactly.
That.
Yeah. They don't see that side of it. We're actually here on both sides. We want to protect our own, but we also know the standard of care. And so
some of the things I've reviewed, I think to myself, what are you thinking? What were you possibly? There's enough signs and symptoms that the medical student would know what to do, right? And that, or the other thing that I see a lot is procedures that are done that are not indicated. That just drives me crazy. And then they have a bad outcome.
Right.
It's colonoscopy that's not indicated. It's surgery that's not indicated. It's not indicated.
Right.
And that's a problem.
Yeah. So along the same line, so now you are, you do a lot of education of residents, and I know that you had stated this in our communication before this, is that you like to educate them ahead of time so that they can protect themselves in a case like this, or take the right steps. So how often do you go about it? I'm guessing it's on a daily occurrence. You're educating the residents on how you can protect yourself or taking the right steps. What kind of advice do you typically give on a regular basis to the physicians?
Well, so definitely there's daily teaching. I mean, I have patients in the hospital now, and we talk about the patients. We do have several weekly conferences that this comes up. Probably the most important conference for all of us is our morbidity mortality conference. And so when you're in a teaching hospital, every week we go over the previous week's, all the cases, the chief resident, and there's 5 surgery residents, there's 6 or 8 surgery attendings, there's medical students. So there's a group of about 25 of us every week, different residents rotate. And we go over all the cases. And as we're going through the cases, let's say they did a colectomy, and I'll ask, this is also teaching and educating, helping the residents get ready for the boards. So in order to become board certified, we have to take a written test, then we have to take an oral test. Well, if you've ever done an oral exam before, it's very different than a written exam. You're in a room, now on Zoom because of COVID, but in a room with 2 attendings, and it's question. You can't fool around. You can't make up an oral exam, right? In a test, you can pick A, B, or C, but in an oral exam, and they can sway the conversation any way they want, right? So we all do the same thing to the resident that presenting the right colectomy for a cancer. So I might say, well, hypothetically, if it wasn't cancer and it was a big polyp, what operation would you do? I would do the same thing. Well, what if there was a cancer on the right and a cancer on the left? Now what operation do you do? So it's that type of thing to see if they can come up with the answer. So let's say you get in the OR and you do the colectomy and you check your anastomosis and there's air bubbles. What are you going to do? Right. So it's those type, and a lot of what I'll do is based on a previous case, right? So I had a case several years ago where a surgeon does a thyroid operation. The next day, the patient loses their airway temporarily, and the surgeon sees that there's a big swollen hematoma. And unfortunately didn't do anything about it, but 15 hours later, then loses the airway again, codes, and dies.
Right.
We're presenting, there were a couple of weeks ago, they did a thyroid. So I said, so hypothetically, post-op day 1, Dr. X, this patient has an arrest and has a hematoma. What are you going to do? And then I'll explain. They usually come up with an answer, not all the time, but usually they're pretty. And I'll start with the medical student, go to the first year resident, see who gets the answer, and explain and say, listen, this is standard of care that's why all these thyroid cases, we have an emergent cricothyrotomy kit at the bedside, because if they have a hematoma, they lose airway, your patient's going to die, right? So that's how I kind of incorporate cases that I've reviewed with the residents, because we're doing the same cases.
Yeah, and I'm sure they're very receptive of that, because I know on the nursing side of it, I do something similar in our staff meetings. Ever since I've been in this medical legal world, I'll bring up situations, kind of the same thing, scenarios. What would you do? And I will tell you that they are incredibly receptive, because they don't want to do the wrong thing. So I'm guessing that you have the same sort of response. It's like, okay, they're really engaged. They really want to know. It's very valuable to them. And it's like a gift that you have. That's what I think.
And we put them on the spot in front of a room of 20 people. And that happened to me. That's how I learned, right? And the questions when I was a junior resident, that's okay. That's how you learn. It's better. And when they get all flustered, I say, listen, it's better that it's me asking you the question than an attorney 10 years from now, right? You're not going to kill anybody right now. It's just right.
Yep.
Right.
Better prepare you now than on the spot then. Yeah, absolutely. Yeah. So then we talked a little bit ahead of time as well, as far as the value of the nursing side, because I know I would love it. I would love to be in that same room. Us nurses, even though it's the scope of what decision making you would make as a physician, we as nurses like to know what those decisions would be as well, so that we can anticipate. And clearly I am an OR nurse, because I speak on anticipation, because we want to be able to think ahead. So how can we as nurses collaborate with the physicians in understanding, their scope, or how we play a part in that?
Yeah, and that's a good question. I will tell you, it really depends on both the nurse and the physician. So, I'm partial to nurses. I married one, and my daughter's a nurse. So I like nurses, but that's just me, right? Because nurses, when I was an intern, saved my life, because I had no idea what I was doing. And I know that, and they knew that. It's July 1st, 1987. Are you kidding me? I get a call from the nurse about vent settings. I've been a doctor for 2 days. What are you calling me for?
Right.
I know the beeper, but I don't know anything, right?
Yeah.
It's you go from Friday, the medical student, to Monday, you're the resident. Yeah. So your doctor, now I'm supposed to know everything. I didn't learn anything over the weekend. Okay, I promise. Yeah. So nurses saved my butt. But I think a lot of it goes back to education. It's on the nursing side. You have the basic understanding of a post-op colectomy, and they're having abdominal pain, and it's really questioning when you're reporting the information. Hey, Mr. So-and-so is having more pain, and they're a little bit more tachycardic, and he's a little bit more distended to my exam, because you're the eyes and the ears of the patient. We're not there all the time. It's so usually when I get that call, I'm an out loud talker, and I do that all the time, even when I'm talking to patients. So say, well, he's post-op day 3, we're treating him for urinary infection. I already looked at the x-ray this morning. It looks like a little bit of an ileus. I kind of talk out what I'm thinking, and I think that helps versus a lot of, and I yell at the residents if I hear them talking to the nurse, of just when a nurse will call you with an issue, a report, just to say, okay, thank you, but no thought process, like, either I'm not concerned about it or I am concerned about it, but I'm doing 1, 2, 3, and this is what I'm thinking. So I think that's it, but it's both ways.
Right. Unfortunately, yes, it is a two-way street. Okay, it is helpful to know that, and I think that's just intercommunication between physicians and nurses. It's always a hit or miss. Some are great and some are not so great. We also talked a little bit about how our medical legal side of we're trained to go through these electronic medical records. And we were talking about how valuable it is to collaborate between the physicians and the nurses for that reason, because, your head is not buried in a record typically. Just what you need to know in the record. And like we said before, the electronic medical record has made things more challenging, because there is so much information in there. There's a lot of duplications, and what would you say? How would the legal nurse help the physician in their side of the reporting? Because I know that there is an attorney I work with who has a physician he works with often, but does not rely on my reports, but he really finds the reports valuable to him. It saves him time and energy looking for those things. So can you speak a little bit on that?
Yeah, I mean, if it was up to me, I would have every case that I'm asked to review, have a legal nurse consultant review it and make a chronology. I mean, the way I look at it, the electronic medical record is information overload. If I get 1,000 pages, there's maybe about 50 that are important, right? I need to know the history and physical. I need to know which is everything past medical history, what's happened to the patient, how did they come to the hospital, why are they getting surgery, what the surgery is, and every day afterwards, what's going on. But, I cannot tell you the number of electronic medical record systems I've been on, all of them, right?
Yeah.
In all the hospitals when I was in Atlanta, everyone had a different system.
Yeah.
You got to be kidding me. Right. I mean, CERN, Epic, you name it. I've been on all of them. Meditech.
Right.
I hate them all.
Exactly.
So, but, I'm, from a physician standpoint, is I need to opine on the physician, what the physician knew at the time, what should they have done based on how the patient. So I'm looking at the progress notes. I'm looking at the operative notes. Sometimes embedded there are the nurse's notes. And I don't know if it's copy paste. I don't know if it's automatically dragged in. So then you got to get all the pages of nursing notes, and you've seen the volume of nursing documentation. You want to put a needle in your eye. I mean, it's just so much nonsense.
Right. Yes.
But it is. You got to do the head to toe. You got to do all the peripheral pulses. But, if it's a colectomy case, I need to know the abdominal exam. So having the times, which are many, that I've had records from the legal nurse consultant, not necessarily a report, but the chronology. Here's the history. Here's the past history. Here's the operative note. And it makes it really, really easy. For sure.
Okay, that's good to know. And also, I think it's, it's efficient. And we were also discussing a little bit about, the cost of having a physician review these records versus having a nurse. Supplementing that or collaborating on that may be cost efficient for the attorney in the case.
I said, look, you sent me 20,000 pages of record. Happy to charge you my fee. I'm very expensive. Yeah. However, this is a pretty simple, straightforward thing. If you get a legal nurse consultant to go through it, give me the bullet points, the things I need, and I guarantee a legal nurse consultant knows what I need because it's a surgery case. It's not rocket science. It'll save them. Sometimes they agree, sometimes they don't. Okay, that's fine. So, I mean, but it can take. I mean, it could take me 10, 12, 14 hours sometimes to get through it.
Sure.
I want to miss it. Sometimes you see some of these records, there's one little statement from the nurse. I reached out to the doctor and no response. And, miss one thing, it makes a whole difference of the case. So
yeah, absolutely. It's the one line. You're looking for the one line, the needle in the haystack. And if you have 14,000 pages, I know I had one recently. It was 14,000 pages, and I'm thinking there's no way the physician wants to go through all of these records. And there were a lot of those, drop downs, or you've got the flow sheet and you've got the same information 8,000 pages later in a different form. I mean, I don't mind going through them because I'm so used to just looking for the right things and finding those things. And it is actually really rewarding to know that the physicians find that information useful, because we want to help, because we're nurses.
Yeah. Well, and I will tell you, what I found over the years too, because I've been doing this for a while, the medical legal things, and is when I go into a deposition, my goal is to know more than the opposing counsel, to know this case better than they do. Now, they've been poring over this case for a lot longer than me, right? Whether it's defense or plaintiff doesn't even matter. But I want to have dates memorized. I want to know when the antibiotics were started. Well, doctor, when were the antibiotics started? Well, they were started on post-op day 3 at 3:00 if you looked at the records, counselor. Mm-hmm. That blows them away, right? It blows, because they don't think you know that chart. But it takes time. I mean, again, I will tell you that the physicians that I know, because I've been on other cases and I have colleagues that do it, sometimes if it's a complicated case where there's been a GI and a hospitalist and a surgeon, that there's multiple experts on it. The ones that do well spend a lot of time in the chart. You have to know the information better than the opposing counsel, because they will come up with the one thing you don't know that? You don't think that's fair? You're opining against a colleague and you don't have that information, doctor? Don't you think that's not right? So it's really important to know the details of the case. And if again, I say this to everybody, if I do well on the deposition, either the case goes away or the other side writes the check, right? And none of them want to go to trial, most likely, right? They don't want to.
Right.
On the defense side, they want it to go away. On the plaintiff side, they want that check. And that happens 90% of the time. I mean, 90% of the time, most of these cases settle.
Right.
So,
yeah. No, that's actually, I was just thinking of this particular podcast. This is really valuable to not only the nurses listening, the typical legal nurses that are listening. We love you. I love you. But any physicians that are going down this road, and I do know, some surgeons that are new to it, that I've been blessed enough to hand off some cases. This is incredibly valuable to them as well, understanding that side of it from someone who is seasoned at doing this. I also want to touch on, the attorneys who may listen to this podcast, and how you can share the value, because a lot of the times we're educating. I mean, they know who, the physician experts are. That's who they're looking for. Typically, we'll get an email that says, hey, do you know, a colorectal surgeon? Yes, I do. Here's one, right? And that's the value that we give them, because they don't understand what else we can do for them. So educating attorneys on the value of the nursing side. I know we touched a little bit about that, but I would love for you to not pitch, but educate the attorneys out there, because you've educated the physicians, the nurses, and educating the attorneys on how it is that the legal nurse consultants can benefit their cases, as well as, obviously the physician experts or nursing experts. I think in the old days we were just looked at as those that could either find experts or those that were testifying experts.
Yeah, I mean, it really gives a lot of value. I mean, there are probably about, I don't know, a third, maybe closer to somewhere between 30 and 50% of the time, if I'm looking at a plaintiff case, happenstance, I will, by me looking at the chart and knowing what I'm doing and what I'm looking for and what happened to the patient, I'll say, did you also sue X, Y, and Z? They go, what are you talking about? I said, listen, the surgeon did this, but I think the radiologist missed the X-ray. I looked at the films. It's very clear that it's different than I'm not a radiologist. I'm just saying, but I can't opine on something not in my specialty. But if the hospitalist was seeing the patient for 3 days in septic shock, knowing this patient had a right colectomy, why didn't you advocate for the patient? Same thing on the nursing staff, right? So I will tell the attorneys, and this is something that legal nurse consultant, again, attorneys know the law, nurses and doctors know the medicine. We don't know the law, we know medicine. Right. They know the law, they don't know medicine. They need the help. And my guess is many times by getting more than one specialty involved, i.e. an expert witness to what they think the issue is and a legal nurse consultant, they may wind up suing somebody else. Well, that's more money for them, obviously, right? If you can draw other people in. And the other thing I found, especially, and I tell the residents this all the time, when multiple individuals are being sued, let's say anesthesia and surgeon and nurses for the same thing, they tend to want to blame the other ones. And if they start pointing the fingers at each other, everybody's writing a check. And I've had that happen in a case. I was on a plaintiff case, and it was a disaster case. I won't go into the details, but the ER doctor at midnight called the colorectal surgeon, told him the report of the X-ray. The surgeon said, I'll see the patient in the morning. Click. Patient wound up 9 hours later, septic shock and dying. Everybody got sued. Surgeon, the hospital, the ER, everybody had touched a patient, right? And it was a disaster case. Right. And what did the ER doctor say under oath? I told the surgeon what was going on. I can't make him come in. It's not my fault. Surgeon, the ER doctor didn't tell me how sick the patient was. If he did, I would have come in. Everybody paid. Right.
Everybody's pointing fingers. Yeah.
Right. So back to the question you asked about the benefit that a legal nurse consultant, things like that, right? Things like that. Did the nursing meet the standard of care? Did they elevate to the next level? Did they tell the nursing supervisor? And I've seen this before, nurse will call the doctor, no response, and then no follow-up. That's not standard of care. You're calling the doctor for a problem. Why didn't you follow up? Right? You can't say I'm busy. No. The juries don't care about that, right? Yeah, we know everybody's busy.
Everybody's busy. Yeah.
Yeah, you say that. So,
yeah.
I think that's a huge benefit that attorneys don't know, right? They only know what they know, right? The client comes to them, I got hurt, here's the story. Sure, let me figure it out. But they don't know medicine, and they're not supposed to know medicine. It's not their role. Their role is to legally, find out if it was a breach or defend the breach, and was there harm that they can make a legal claim.
Right. And it can be multifaceted. It can be
many times it's multifaceted.
Yeah. More than one person dropped the ball. Okay, great. So I would love for you to share how we as legal nurses can help you out, because, this whole podcast is lifting each other up. It's, how can we support each other in each sort of area we're in, if it's something that we can support you, if there's something that you are, teaching or sharing, or even just, reaching out to you if we are, because again, we are constantly asked for testifying experts on certain topics. Obviously, now you're top of mind for me for colorectal surgery. How can we help you out?
Usually, people remember me when I examine them, but you kept your clothes on the whole time. So there you go. So yeah, it's usually
I get to do the podcast instead.
They come up to me in the mall and say, "Dr. Cohen, do you remember me?" And I usually have to tell them to pull their pants down because I don't remember them. But that's the norm. But no, I mean, you're helping me just being on this podcast for sure. But I will, when I made the switch from private practice into more of the academic world where I am now, and I had all this time on my hands, and my wife kicked me out of the house to go find something to do. That's the only time. That's the time that I started marketing myself as an expert witness. I never did it before. I was in it. So the first 20 years, I'm in Atlanta. Atlanta's 4 million people. I was busy as can be. I knew all the community. I knew everybody. But then I left. And one of the things I realized, and even though I left the group in good terms, and my younger brother, who I was in practice with, also a colorectal surgeon for 10 years, obviously I'm still friends with him. I'm related to him. Right. Even if I don't like him, it doesn't matter. I have to be. But the unwritten rule when you leave a practice is they don't give any forwarding information. I don't know. It's just one of those, I don't know. So when people would call the office looking for me, Dr. Cohen left the practice. We don't know where he is. Okay. Yes, you do. Okay. I know you know. Right. I decided at that point to market myself online, and I didn't even know what that meant. I had my son help me, whatever. I didn't grow up with computers. It's not my fault. So, but then I stumbled upon the American Association of Legal Nurse Consultants back in 2016. I didn't even know it existed. I didn't know what that was, right? I'd run into legal nurse. I didn't know you guys have like a thing. You have an annual meeting, you talk to each other. That's the greatest thing ever. So 2017, I did I was at their conference down in Clearwater, I think it was that year. And that was great. A room of 150 legal nurse consultants. Everybody's, they're not new nurses. They're 5 years or above. They know what they're talking about. It's great because I'm teaching anyway. So every year since then, except for COVID, because that was the off year, I've been part of that group teaching, picking a topic. Yeah. Next year they're doing it virtual. Yeah. Instead of in. But it's been great. I mean, I get a lot of calls now from legal nurse consultants just running a case by me, which is fine. Do you think it's a case? I get one of the common things that I've seen recently is a splenic injury of the spleen from a routine colonoscopy. During colonoscopy, believe it or not, that's a known entity, and it's not a breed, right? I mean, if it's recognized, there's a ligament that goes from the spleen to the colon, the splenocolic ligament. And just by tweaking the scope, you can tear it off. Yep. It can bleed, usually stops, sometimes requires surgery. But that's a known complication. Yeah. I tell the residents there's no complication they can do that I haven't already done. That one I haven't done. So that's probably coming. But it's recognizing, again, it's not the complication that's the breach in the standard of care, usually. Right? We know there's complications. I mean, surgeons that say they don't have complications, either they're not operating or they're lying. I mean, it's one of the two options. Right. So it's failure to recognize the complication in a timely fashion, then that leads to the bad outcome. Fistula, the loss of bowel, death, a lot of sepsis cases. So that's important.
Yeah. You're speaking my language. I can picture the anatomy right now. I do a lot of robotic colon surgery, so I can picture it. All right. Well, I'm glad that you're a part of the AALNC community. So that is one way to stay connected to Dr. Cohen here, and I'm sure that you will get an influx of hellos Where can we find you as far as marketing goes? Are you on LinkedIn? Do you have a website? Where can we find you?
So I don't have a website. I'm not that savvy, but I'm on LinkedIn. So if you're, and do you think most of your legal nurse consultants part of that group, AALNC?
Most of them are. They're they are. It is kind of the North Star for.
Right. And I would say if the legal nurse consultants that are not, that are listening to the podcast and not on it, that is a great resource and reference. And I've referred nurses that are wanting to get into it. This is where you start, right? Yeah. They have the white papers, they have the books. How do I do it? How do I market? And everybody that I've met at the higher executive level want to have nurses come in, just like what you're doing, to take them. They're more than willing to help. Now, it probably seems weird for nurses to hear me say that, because I know what it's like for nurses. Like I said, my wife's a nurse, my daughter's a nurse. Nurses like to eat their young, and nurses are so senior to other nurses. I mean, my wife is actually the dean of a nursing school here in Virginia, and I mean, I have heard her yell and scream at some of the other nurses, and I would never do that. I'd say, how do you get away with that? I could never yell at them. I can't do that. So I'm not going to yell at the nurse. Yeah. So, but everybody at that level, at the executive level that works with, at AALNC, very receptive and warm and wanting to help. And it's really a great organization, I think. And it's,
I agree. It's funny that you said that, because that subject comes up just about every podcast about eating your young. And the great thing about the podcast and that AALNC community is that it is a group, and I try to really be a part of that, the culture that is the opposite of eating your young, because I've been a nurse for 24 years. So I have seen it all, and really trying to change that eating your young culture is something that we're really trying to do.
You don't do that in medicine. I mean, I think maybe 30 years ago when I was trained, I was yelled and screamed at a lot. I think, even looking back, I think it made me better. But that's what they taught in the 80s, right?
Yeah.
Now, if I yell at them, they go tell their boss, I get a mean letter. I mean,
it's different now.
Very different now. So
it's different now. Yeah. So we're trying to also, head in that direction, especially in this legal nurse community, because what I found when I first started in here, there were these two camps of people, and it was like, wow, I didn't know that this existed here, and I wanted to help, create this environment where like everybody is welcome, our job is to lift each other up. Everybody wins. There is no competition. We're all nurses. We all have different specialties, but there's plenty of work out there for everyone. And as long as we lift each other up, everybody wins. It really, really, really. So I'm glad that you mentioned that, because that is really what we try to not preach, but it comes up in every podcast. So I'm glad you brought that up.
So,
all right. I'm sure. Yeah, go ahead.
Stephen Cohen. I'm in LinkedIn, and you can put in the show notes. I have an email. So people either email or call me, but through LinkedIn, it's all my contact information.
Perfect. Yeah, that will all be in the show notes, and I'm sure that you will have those legal nurses out there reach out and say how much they love this episode. So I really appreciate you spending your time with us here, and I love our conversation. So thank you so much.
Thank you. I appreciate it. Thanks for the opportunity.
Thank you for joining us in this fun conversation on the Limitless Legal Nurse Consulting podcast. I hope you found this episode as inspiring and empowering as I always do. And I hope that you share this episode with your friends. If you enjoyed it, I would love it if you could leave us a review or comment, as I would love to share them in the future episodes. Or hop on over into my DMs and send me a quick message. I can be found on Instagram at anna.b.gray, on my website at limitlesslnc.com, and over on LinkedIn at anna.gray. And I want you to remember, you are limitless. Until next time.